All right. So you are here in Game On for Informed Consent, fresh takes with fun facts. Hopefully, we did have a room change, so hopefully that is where you wanted to be. If not, now is your chance to go to the other room, which is that way, on the international education applicants. But I think you want to stay here because we are going to have fun. I mean, any session with this amount of candy up front is going to be fun. So, my name is Missy Anthony, and I am a member of the Education Committee, and I am so excited to welcome you to Game On for Informed Consent, Fresh Takes with Fun Facts. This interactive session reinvents the way we think about informed consent in physical therapy with a game show twist. Even those of you in the back better be prepared. As you test your knowledge while exploring ideas about consent that you've never heard before. The speakers for this session are Jennifer Holland, Karen McIntyre, Christina Lounsbury, and Cherise Smith. They are all members of the FSBPT Informed Consent Task Force, and you can find their bios in the event app. They have valuable information to share, and we also encourage your participation. Apparently, they are going to bribe you. And if you wish to ask a question during the Q&A portion, this is very important. The members of the Education Committee will provide you with a microphone. So wait for the microphone. Please, 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 pretty please. Please abide by the ground rules in the program notebook so more attendees can have a chance to ask questions. At the end of the session, please scan the QR code or, oh no, it's not up there yet. It's also on the sign outside the QR code to complete your evaluation. Your feedback is important. So now I turn the presentation over to these lovely ladies. Thank you.
Thank you. All right. So the theme of this talk today is going to be Jeopardy, because we don't want to put the public in jeopardy by not taking informed consent seriously. So I am Christina Lounsbury. I'm one of the co-chairs of the task force. Cherise could not be here today, but we're very lucky that Kelly King was willing to step in and help us out. But I'll be presenting with Karen McIntyre and Jennifer Holland, and then of course the additional members who are not here today. But I will tell you that when Leslie first put us in a room, she sat us down and said, we are going to define what informed consent means and looks like in physical therapy. And so that didn't sound too hard. 6 months later, we knew what it meant and looked like in all the other medical professions. About 3 months after that, we knew how it was defined and what it looked like for physical therapists in other countries. And 2 years later, we are now able to present what informed consent, what the definition is, and what it looks like in practice here. So first of all, just to be serious for a second, why as regulators are we even talking about this, right? Why this importance suddenly on informed consent? First and foremost, it is paramount to public protection. It is the best way for the licensee to protect the patient and to protect their own license. It levels the power imbalance and helps ensure patient autonomy. It's the best way to share knowledge, and it allows the patient to ask questions and express concerns. Most importantly, it gives the patient permission to say no. Research actually shows that there are better outcomes when informed consent is the focus of the treatment. Patients have a swifter recovery, and they have increased patient satisfaction. And it prevents miscommunication during the course of treatment. We've all had cases brought before us where everyone says, they didn't tell me it was going to hurt. They didn't tell me how much it was going to cost, how long I would have to go. They didn't tell me I was going to have to exercise, like all these things. And so that can all be addressed through informed consent. And so it also sets up expectations for the patient, and it keeps the physical therapist accountable to the agreement that was set forth. Probably also just as important, it is both a legal and an ethical requirement right? And it has become more and more under the legal microscope in recent years. No, sir. Okay, thank you. I don't know if any of you remember TiVo. I had a TiVo, I'm not old. And you used to put in your preferences, and then there was the joke going around, I feel my TiVo judging me. Leslie tells me all the time she feels my Google is judging me because after 5 years of researching sexual misconduct and informed consent, these random articles start popping up now. And so this one came up, and I thought it was really interesting, and I have to read it because it's pretty involved. But this is how complicated informed consent is becoming. An OBGYN diagnosed a patient with a severe case of endometriosis and advised the patient to undergo surgery to remove the left fallopian tube and ovary. The patient did not consent to the removal, okay? So then later, the OBGYN referred the plaintiff to a surgeon to discuss colon surgery for the endometriosis. And the surgeon scheduled the patient for a laparoscopic colon resection. Prior to the surgery, the OBGYN and surgeon engaged in a pre-surgery discussion without including or informing the patient. The patient said that during these discussions, the OBGYN recommended to the surgeon that they remove both the plaintiff's ovaries. The OBGYN never told the plaintiff about this recommendation. The physicians planned to perform the operation together. Ultimately, the OB was not able to attend, so the surgeon, who was doing the colonoscopy, removed the ovaries during the surgery without the OBGYN being present. When the patient awoke, she found out that she no longer had ovaries and would no longer be able to have children. She was never informed that this was part of the surgery. She sued the surgeon, and she also sued her OBGYN. The OBGYN asked for the court to have her dismissed from the claim because it was not her responsibility to obtain informed consent before the surgery. It was solely the responsibility of the surgeon. And the court ruled that the OBGYN made the diagnosis, referred the patient to the surgeon, and remained the primary treating physician for several months after the surgery. And while the OBGYN was not the physician who removed the ovaries, she played a direct and influential role in the surgery. Ultimately, they decided that under the rule, a physician who treats could potentially include a physician who may not have actually performed the operation or treatment, but still had a role in treating the patient. So, that's an example of how complicated informed consent is becoming. And especially in the hospital settings, I work in outpatient, so it does remain somewhat straightforward. We get a lot of questions from therapists working in the hospital. Who obtained the consent? Am I supposed to obtain the consent? And the ruling is becoming more and more that everyone involved in the treatment is supposed to obtain some form of informed consent. So, these are the projects that we have completed over the last 2 years. We have the official definition. Like I said, we reviewed the state practices. We did a multidisciplinary review and an international review of informed consent. And from there, we made a resource document for all the jurisdictions. We took all the information we found, and then we kind of summarized it down into the most important documents for you to reference. And so we made that into a resource so you would have access to those. We also have the Informed Consent Guide for Physical Therapy, which is a how-to for physical therapists on informed consent. We have the Quick Guide or Mnemonic, which we'll go into a little bit more, and we have developed an educational model. So let's talk about the definition of informed consent. I'm not going to read it because it's long and you all can read it, but this is basically what informed consent must include. So it must include the following: an explanation of the intervention in lay terms and identification of possible providers of the intervention, so any PTAs or techs, or other therapists that may be involved. Disclosure of risks associated with the intervention or the lack of the intervention. The expected benefits of the intervention. Informed consent may be withdrawn in total or in part at any time. They can take all their consent away, or they can just say, I don't want to do that aspect of the treatment any longer. And they need to know that they can do that at any time. We must discuss any reasonable alternatives to the intervention. Review of anticipated timeframes and costs. And most importantly, we have to give them an opportunity to ask questions and express concerns. All right? Nowhere in this definition does it say that a signed piece of paper obtained while the patient is alone in a waiting room, or an electronic signature obtained while they stare at the back of a computer screen is the same thing as informed consent. Okay? Informed consent is a conversation. So, great documents, and we're going to go into more detail, but first of all, I want to let you all know where you can find them. So if you go to the FSBPT website and then go under free resources, and then they put another button to make it more complicated, there's more resources, and then regulatory resources, and then finally informed consent. And everything that we're going to talk about today can be found there. So I'm going to turn it over to Jennifer.
Hi, good afternoon. So our task force referred to a variety of resources during the past 2 years as we were working through our projects. Some were published by CMS, the Joint Commission, the APTA, but as Christina mentioned, we also looked to information from international physiotherapy associations. There are some countries out there like Canada with well-defined guidelines for informed consent. We did also look to information from other professions. As you can imagine, given the nature of medical practice, informed consent has been well documented in both their literature and frankly within case law in that discipline for quite a few decades. So that was a helpful starting point for our task force. We are very excited to share with you the fruits of our collaboration for the past 2 years, starting with the Informed Consent Guide for Physical Therapy. This is concise but thorough information on how to incorporate the principles of informed consent into the practice of PT. We start with our definition of informed consent, and we progress into a conversation on why this is even important. What is the value to the community at large, certainly our patients, but to clinicians alike. And on that note, we walk clinicians through the process of obtaining informed consent. I know I talked to a lot of you last night. There remains the misconception, even among seasoned clinicians, that informed consent is that generic form patients are signing upon intake. If nothing else, our task force really wants to clear up that misconception. But in the spirit of fairness, we want to educate PTs and PTAs what those professional standards are, what are the critical elements of obtaining informed consent. Within the guide, we also review the different types of informed consent, explicit versus implicit. Explicit would be great. Exercise and joint mobilization sounds wonderful. Let's go ahead with that. There's also implied informed consent. The standard example would be someone asks, can I take your blood pressure? The patient sticks out their arm. That is implied consent. There are times when we do recommend explicit rather than implicit consent, and we review that in the guide. We also explore the timing and responsibility for obtaining consent. Basically, is informed consent a one-time conversation during the evaluation? No, it really isn't. It's an ongoing communication with our patients during the episode, especially when we're introducing new modalities or proposing new modalities, okay? And then in terms of the responsibility, is this something we can delegate to our front office staff? Or for those who have worked in home care like myself, Is this something that the start of care nurse can do for us? Your home health agency might tell you yes, but no. This is not a delegable task. This is a profession-specific task that we therapists need to do, okay? We talk about capacity issues. Pretty much all of us clinicians will run into capacity issues in our career, whether we work with minors or adults who have impaired cognition. This could also be a temporary change in capacity. Imagine a patient who's well but has been admitted to the hospital with delirium. They have a temporary change in capacity. Are we as therapists doing a good job identifying capacity issues? And if there is a capacity concern, are we finding the legally authorized representative and involving them in the informed consent process? That's something we probably need to do a little bit better with, okay? Section 4 of the guide is information sharing and exchange. So if the whole idea of informed consent is that the patient is adequately educated and empowered to make their own healthcare decisions, are we as therapists creating an environment where that can actually happen? Are we communicating with patients in clear and plain language, or are we using a lot of technical jargon? Are we listening for patients if they might be expressing that they're not fully on board? What language are they using? Are we using visual aids in our teaching? Are we inviting input and questions from our patients? And are we making it clear to our patients that they can withdraw or modify consent at any time? I mean, do you feel like your patient could say, you know, I want to keep going with joint mobs and exercise. I don't really like electrical stimulation. Can we talk about changing the plan of care? And lastly, every therapist's favorite, the documentation of informed consent. Is this required? Is it recommended? Maybe there are certain circumstances we would recommend it a little bit more heavily. And if so, what are the components of that documentation? Now, how do we envision this guide being used? Ideally, we'd love to see the content of this incorporated into academic settings, okay? We know when we learn certain good habits early on in our career, they're just easier to adopt than later on. I hope I can say that. A little fun fact about myself, I come from a family with a lot of dentists, and many of them were educated in the 1980s. I've had to hear the same unsavory story so many times at the dinner table, that dentists prior to that era were not using gloves widely in their dental practice. Okay, my relatives went to school in the 80s. They just learned all of their procedures with gloves on, so it was not a big deal for them. Their mentors who had been in practice 20 and 30 years really struggled to do those procedures now with the gloves on, a totally different sensation. From what I understand, a lot of them waited to the last minute when it was mandated, I think in 1991, okay? That's an extreme example, but I think it's true for all clinical habits. If we can just get new therapists learning this skill early on, it would be best. And on the other end of this, I think this content would be fantastic for continuing education programming. Maybe your state has an ethics or a jurisprudence requirement. This would fit in quite well, and it would also work well as a remediation tool. Okay, so knowing that adopting good informed consent practices might be a little bit tricky, we have devised a quick guide mnemonic to all of the essential components of informed consent. Ideally, we'd love to see it maybe laminated, put on the back of your name tag if you're working in a clinic or a hospital, or saved onto your computer. This might age me a little bit if you're still using a clipboard like I do. Maybe, I don't know if they're doing that anymore, I do. But putting it in your clipboard, the mnemonic spells out the word consent. So C, again, communication in non-technical ways. O, options. I have to tell you, this has been the most difficult component for me. I am not used to saying to a patient, hey, if this doesn't look like a good choice for you, you could consider acupuncture, a personal trainer, heaven help me, a chiropractor. We're not used to this because we believe in our profession, right? But it is an essential component to informed consent. Also, doing nothing at all is an option, and we can explore that with patients. N, necessary disclosure, the anticipated benefits, risks, and outcomes of treatment. S, E, and N, I would really consider the true spirit of informed consent. It's shared decision-making, empowering autonomy in our patients, and nurturing trust. And T, transparency, also a little bit difficult, is sharing the anticipated timeframes. Is PT looking like 2 weeks in the home setting? Is it looking like 5 months after a total knee replacement? As well as anticipated costs. So we have also devised an education module. The module bundles together our mnemonic, our informed consent guide to physical therapy, as well as some of our learning activities. Each of the learning activities has a sample scenario. I think they're fairly realistic, and they contain one or more dilemmas that is common in the informed consent world. We ask learners to spot the issues and to propose ways of mitigating or doing a better job addressing informed consent if this scenario was to actually happen. And with that, I think I'll pass it back to Christina. Yep.
Okay. Also included in our education module is a learning activity number 2, the Jeopardy game for informed consent. And you all are so lucky because you get to play that today. And we're going to try it out and see how it works. But before we get rowdy with the sugar and the prizes, we would like to open it up to questions. So if anybody has a question, be sure to ask for the mic.
Thanks so much. I have one quick question. Where is that module found? The educational module?
The education module would be on the website with the other resources. So it's the FSBPT website under resources.
Yeah,
and
I have
then-
the informed consent. I just have,
Oh, you know what? It may not be approved yet by the board.
okay.
So it will definitely be up by January. It may
Okay.
not have gone through the complete approval process
Okay.
yet.
And then how do you suggest, so working with adolescents who are unfortunately very cognitively intact and are just, adolescents. And there you go. And I mean, their parents are, on top, of course, but they don't necessarily want to do things.
I'll take a stab at that one. What I'm hearing you say is that you're wondering how to get a patient who's an adolescent to agree to your treatment plan or agree to what you.
They're yelling out, "I'm not agreeing to do this."
Oh, yeah, yeah.
They're very smart, and then they know some of the buttons to push, and then everyone's like looking at.
Yeah, that can be super challenging, right? And sometimes it's in the why, like why is it that we need to do this? What is it, why you're here, what your goals are, what the outcome potentially could be. But, certainly the parents are the first line of informed consent, and that's going to be the case in treating anyone who's under, right under the age. And there's been a lot of scenarios about, well, I've got a 17-year-old athlete who comes to my office and he drives himself, so his parent's not there. How do I get consent and things like that? So, I mean, I really think that at the end of the day, you may not be able to do what you need to do with this adolescent who is just absolutely refusing to let you do what you need to do, and you send them away and they don't meet their goals, right? Like that's the end of the, you know what I mean? It's a hard thing. It's a hard sell. I mean, having an adolescent period to just even brush their teeth or clean their room is a hard sell, but much less do something, but reminding them why they sought therapy, what they're there for, what their goals are, and hopefully they get some buy-in. Also partnering with them, like, this is what I want to do. Do you have any ideas of how we might do it? And having them maybe come up with an idea. Like, we need to work on jumping or whatever. So having them join you with your plan.
I'll just add to that, we do have a scenario in the
okay.
module that deals with minors. It's kind of the opposite situation. It's where the minor, the therapist provides treatment for the minor, and the parent, comes to the initial visit, and then they introduce something that they didn't talk to the parent about. And so the modules do have discussion questions for that, and also kind of a key. It's not, it's not perfect answers, but there are, using the principles that we've learned through our work, some suggestions of how you could approach that as well. Once you've kind of established that plan of care with the patient and the adolescent, how do you continue to involve both parties in the plan of care? Because it's really important.
Really briefly, I'd like to just make a mention. If anyone is to speak in the microphone, to say your name and your jurisdiction. Please make sure that happens.
Paul Claponis, Florida. So in the world of level 1 trauma in acute care, where narcotics is the world for days on end, what's the discussion about capacity then? When we know that we're trying to prevent bed sores, pneumonia, PE, et cetera, et cetera.
Yeah, so we did take that into consideration, and there are exceptions to the capacity rules in emergencies and things like that, where the treatment is necessary and immediate. But that is also a section in the guide on how to determine if you're treating someone that cannot give capacity and what your decision-making and documentation would be for that.
Here. Alan Lee from California. You talked about different modalities. How did you guys, the task force, handle things like AI or things like telehealth, or also like wound photos? I practice in wound management.
So we did include statements about AI saying that it was part of the informed consent process. We went very general with it because we don't know where AI is going. But that it is, if you're using it, you need to disclose that, and it needs to be part of the conversation. And like the photos, as long as you get consent, I mean, for the photos, it's part of their patient record. It'll be kept confidential as well as everything else, so.
I just want to quickly add to that. I think another part through our process that we learned was we shied away from a lot of very specific recommendations. Like this, even with dry needling, for example, we don't say you have to have written consent for dry needling, because different jurisdictions have different requirements. We did talk about some examples, but the intent of the guide is not to take the different modalities that physical therapists use and say this is the standard for that. Because every individual and every situation is going to be slightly differently. So as you look at the guide, I would say look at it with being aware of the different types of procedures and things that we use, considering kind of the risks that are involved with that, and the person in front of you is hugely important as well.
Tammy Burles, Missouri delegate. Thank you very much for your work. Finding all these resources will be very helpful. My question is, as we're thinking about the Model Practice Act and things that jurisdictions will be using, is the new definition or where the information on getting consent is required, how will that be incorporated into the Model Practice Act?
We talked about this, and the definition, we recommend that you try to get the definition into your Practice Act. We did not recommend any rules based on that. We just recommend at this time you get the definition in there, and then each jurisdiction to make their own decision on how far they wanted to go with it.
And we reviewed it in alignment with the Model Practice Act language, and we didn't really find discrepancies. We actually had a lot of dialogue at the beginning about the definition. Is it, and we settled upon as the educated decision made by the patient. But the physical therapist does the informed consent disclosure. So sometimes you'll see informed consent referred to as the process the therapist goes through. Sometimes you'll see it referred to as the decision by the patient. I think the key thing here is it's all those things together. It's a process. And so our definition, I think, might be slightly different than how it's worded in the Model Practice Act, but there's no discrepancies, if that makes sense.
Hi, Sandra Hahn from Oregon. My question is really very similar to hers, so I'll just expand on that a little bit. How do you envision how you envision this becoming part of practice and then something that regulators can hold therapists accountable for, and how, especially given how long it's taken for you to develop this, kind of what's your thoughts?
I think for myself, I'm a clinician. I think it's really hard too when the expectations just aren't clear, when it's not codified in law or regulations. I know that's part of what we're talking about here, but I do think ideally that is why we see it being incorporated into entry-level physical therapy and PTA education, to just get new therapists automatically including this in their evaluation, in their reevaluations, in their check-ins with patients, that it will almost become second nature. And then as therapists, I mean, if you're out in the field 20 or 30 years, having a continuing education opportunity like that, but yeah, I think that can be a little bit tricky, especially for those of us who have been in the field for a while. But I really do think that one of the big focuses of our task force was how do we get this into the PT schools? Yeah.
Yes, and to second to that, take a look at what your Practice Act says. Some states, we were very surprised, some states had really clear language. Arizona's got some very clear language about what is informed consent and how often it has to happen and how it's documented. Lots of states have nothing. And so take a look at where your state is and maybe start there. And so we're going to come at it two ways, right? Educating the next generation of clinicians, and then regulating the practice to make sure that that the public is protected, that they understand what it is that they're going to be doing, that they have a right to say no or change their mind.
Deb Mason, Oklahoma. This is more maybe from a clinician hat than regulatory, but it all ties together ultimately because it will affect how these complaints go to the board. What do you foresee the documentation burden on the clinicians in terms of how you convey this in such a way so that the clinician is protecting themselves, which is the whole idea? How extensive does it have to be? Would you be looking at, this looks like this is something that's automatically put in every time? What do you foresee that looking like? And
I am so glad you asked that question, Deb. So now this could vary state to state, I'll acknowledge that, but in general, it's not really required that informed consent be obtained in written form. Patients don't necessarily have to sign off on informed consent the way that they do with general consent, right? But we would recommend that when these conversations have happened, that the therapist does commemorate it within the EMR in written form. And we do in the guide talk about what the recommended components of that documentation would be. What I think is the biggest burden right now, because I wear the clinician hat as well, what I think the biggest burden is getting it into EMR systems, because working in home health, I go and document it, and there isn't a place for this to be contained. If anything, there's maybe a checkbox, but it's really insufficient. We need to make sure that EMR platforms have a way for clinicians to document some of the details of what that conversation looked like, rather than putting the burden on the clinician to try to remember to squeeze it in anywhere within that system. That is what I'd like to see happen next, approaching the EMR company.
Scott Stevens, North Carolina. Kudos to the committee, and my role is past a lot of things. 40 years ago, this issue was before the Federation, and we discussed it, and then I spent a little time at the APTA, and we had conversations, and one of the other board members says, of course we get informed consent. When they come into the hospital, they sign the document accepting care. And then I did about 20 years worth of standards of care witness. So, and that illustrated a whole lot more dialogue, or began a lot more dialogue. You guys have done a really nice job with a process, but the only way that I see that process is going to be implemented, because as a standard of care witness, I'll tell you, I would testify that there is no standard of care. It's in the Code of Ethics, which was the point of view from the board, but it's not the standard of care that this is being done, which is for the defense attorneys in the room. But the bottom line on it is how short of illustrating in case law that the informed consent resulted in an outcome which was not, from the therapist's perspective, good news. How do you get people to change? And I understand the illustration through the education and the other avenues you can go, but this is going to be a bottom line, as usual, pocketbook issue, and you're going to have to figure out how to make the risk involved with not having informed consent be substantial enough that people will be forced to do it, or corporations will be forced for their employees to do it.
So we agree with that. We've provided the information for everybody to implement in whatever way they can through jurisprudence and continuing education and ethics classes and schools, everything that you can get the message out there. But I mean, you can also publish the data in the big conference that Louisiana had last year. HPSO showed up and gave out all the statistics on how much it was costing physical therapists not to go through the informed consent process, and how much these cases are costing, and how much your insurance is going to go up, and what a difference it makes in your career, and the number of boundary issues and misconduct cases that potentially ruin your professional career that started from an informed consent perspective. So, I mean, that could just be another way as regulators to put those, we are protecting the public, right? We want the patients to feel safe, and we can talk about the licensees, but licensees who don't want to be better, licensees who don't want to learn this, licensees who don't want to be more effective and safer, it doesn't matter, they're gonna come before you anyway. So, I think, in the long term, it will become the standard of care. It is becoming the standard of care from a legal perspective. Case law is supporting that. And so we're just trying to help get the information out there to make the adjustment a little more smooth.
Hi, Meg O'Connor, Louisiana. I have a quick question just about communicating risk to patients. I have a background in statistics, and I know that relative and absolute risk, for instance, are really non-intuitive concepts for a lot of people who aren't familiar with them. So if a provider is, for instance, suggesting a modality that has a small risk, like say dry needling in an area maybe around the lungs, but not in a muscle with a super high risk, and they need to communicate to the patient that there is some risk, but not much. But the patient might not have a background to be able to speak quantitatively about that. I think it's probably tempting for the clinician to simplify in a way to make it really clear. I've heard as a patient, clinicians say things like there's no risk of that, when technically that's probably not true. There are just a couple zeros after the dot. So do you have any guidance on sort of a happy medium there with how to be honest with patients while still making it accessible for them intellectually to make that decision and empower them?
I mean, I think I don't know anything about dry needling to start off with, but I think one thing a lot of therapists get very worried about when we talk about informed consent is, do I have to disclose every single possible risk that could happen under the sun? And no, you don't. What you want to do is to inform the patient about the most common risks, any risk that commonly happens. And even among risks that don't happen often, the more grave, the more serious the risk is, you're going to want to be sharing that with the patient. So maybe, there's a small possibility that a patient could fall off the treadmill and break something. So the graver the possible outcome, the more you want to share it, even if the risk isn't a common one.
And just to add to that, Dan Tenenhouse, who's an attorney who was part of our task force, talked about that a little bit, and he actually recommended not really using exact percentages because someone can find a different study. So talking more like Jennifer said, these larger risks or minor risks, those types of language.
Minor serious risks, yeah.
So Paul, from Florida again, you'd be happy to know, I guess, that Florida statutorily requires informed consent for dry needling and for OBGYN pelvic PT. So that's part of the statute now. It has to be done.
Yeah, we found that that was probably the most common thing was statute, to have in statute. But in those states, then it seemed like, and I'm not saying yours in particular, I don't remember, but when we looked at them, they only referred to that, and so didn't talk about general informed consent in some of the language.
Lisa from Pennsylvania. Are there, I know you already missed it for next year, but for some of the people who have been out of school for a long time and might be in a realm where they're not catching the latest things you're finding, maybe make a proposal to present at CSM so that you capture?
Yes, we would love to present at CSM. We really would. And I think there have been some talks about that and making sure that the message is getting out there. Great idea, though. I'd love that.
Hi, this is Jane Baldwin from Massachusetts. The other thing I would advocate is to get hold of one of your delegations and advocate that informed consent be a specific category in our standards of practice, because many jurisdictions have the standard for practice in their statutes to that this is the guideline. So I would suggest bringing it forward as an amendment to the standards of practice for the House of Delegates.
So hello, everyone. My name is Wanda Evans. I'm APTA staff, but in the jurisdictions, I'm licensed in Maryland, DC, and Virginia, so I'm well covered. In reference to CSM submissions, keep your eye out, because for next year's in February, so be aware of that. I also was very curious, as you're putting out this new information, which is great, and this updated information, have you ever considered, I should say, working with the electronic medical record companies that particularly lean towards physical therapy practices? The reason I'm asking is there's one in particular, I won't say the name, but they have a little checkbox, and you just check off consent given. But that certainly is antithetical to what you just mentioned. Maybe it should say, was the conversation had, something of that nature. Or if I know that when a clinic decides on what program that they will choose, perhaps the medical record companies could provide different options. Not saying that you're dictating what they include in their platforms, but that might be an approach to consider. This particular company also will ask, who was present for the, and you can select which person was present. But it seems to me that hearing this great information or having it as an option might be, I should say, well received by the electronic medical record companies.
No, I like that idea, and that's something that we have considered. And I know you all have lots of great questions, and I wish we had more time, but we are supposed to divide this up. So we're going to move on to Jeopardy. If you have questions, come talk to us afterwards. We want to talk about it forever. That's our problem, so that's why we get these signals. So we're going to play Jeopardy. And basically, we're going to have two teams. We got two microphones. We're going to have people line up. You want to play. Yes, you're going to win a prize, and the prizes are all worth obviously the category you pick and the money that you choose to risk for it. The better the prize. And then the winning team, when we're all done, who got the most points, gets these certificates, these little ribbons of excellence, which mean you can answer questions about informed consent as you go out into the world. People can ask you the questions, and you will know the answers. Don't be intimidated.
Christina, where are they lining up?
Okay, so we're going to line up one here, and then one line over on this side.
So one line here with this line?
Yeah, we need people to in fact, we're going to play a song.
Yeah, while you're getting ready, we're going to play a song.
We're going to play a song to help you kind of work your way over.
Where did it go?
Oh, yeah.
Now I don't see it.
Yeah, team one, you're going to win, right?
It went away. Unless this is it. There it is. Okay.
Okay, team one. People, there are nerd clusters.
C is for communication. Let's talk it out. O for option.
You like it?
That's what it's all about. N for necessary, essential and true. S for sharing, explaining something new. Informed consent, C-O-N-S-E-N-T. Empower and educate, that's the key. More than paper, building trust in me. Informed consent, proceeding ethically. is for.
All right, everyone, thank you. Thank you to Stephen Sugar for that lovely AI-generated tune for us.
Nice.
It's going to be in your head all day now. I mean, is that Harry Connick Jr.? It sounds like him, right? An AI-generated version? Yeah. All right, guys. So I get the fun part of leading us through the game here.
Team 1.
All right, team 1's over there.
Let's do, how about capacity to consent for 500.
Okay. All right, capacity to consent is generally defined in terms of 4 dimensions or criteria: understanding, appreciation, reasoning, and this. Okay. We didn't pay enough for the Jeopardy theme song music.
Capacity. Understanding, appreciating, reasoning, and Dude, this is not Family Feud, people.
Knowledge.
Dude.
I'll tell you, these questions are taken from the guide that we put together, so.
Time is up.
Do we have a guess over here? No, let's give the other group a chance. That's a great idea. Knowledge is understanding.
For the steal.
Yeah, they can steal. No, you can steal in Jeopardy. One time, like the other person can.
Cognition. Team 2, cognition.
Cognition. It's not understanding comprehension, it is expression. So being able to actually express that choice. Good, that was a tricky one. I feel like you picked the hardest question on the game, so that's it. Okay, what's next?
All right. Team 2?
Okay, Alex, I'll take documentation for 300.
Documentation for 300. Oh, and please be sure to answer in the form of a question. This type of consent is recommended when risks are serious or common, including for more invasive procedures.
What is written consent?
Correct. Good job. $300. There you go. She's a smarty. All right, what would you like?
Sheka. Oh. Okay, what do you guys want? What? Principles of consent for 300, please.
Principles of consent for 300. When implementing physical therapy interventions on an ongoing basis that the patient or client has previously consented to, this person is responsible for informally reaffirming consent.
What is a provider?
Correct. And so the point we want to make here on this question is that both physical therapists and physical therapist assistants have a role in the consent process. Physical therapist assistants have a role in the consent process. And so even though the physical therapist is responsible for obtaining consent initially, and when the plan of care changes, the PTA who's working with that patient, it's important for them to obtain that as well. All right, back to the board.
Okay, definition and importance for 200.
All right. The informed consent disclosure includes several key pieces of information that the provider must discuss with the patient or client. Name 2 of these. Yeah.
What is the risk and what is the benefit?
Excellent. So, good job.
Good job.
So there's the list of all the things you could include. All right, where are we at? Over here now, I think?
Principles of consent for 500.
Okay, going for big money here. Informed consent must be obtained again when this happens to the patient, client's condition, capacity, or plan of care.
What is change?
Yes, significant change, yes. And this must also be obtained by the physical therapist. I know, we did our best. Some of them were,
All right, where are we at over here, Michelle?
Okay, let's go with documentation for 400.
Documentation for 400. When informed consent is obtained verbally from the patient or client, documentation in the medical record should include this. This is kind of a tricky one. There may be multiple things. Just think of something you might want to.
That risks and benefits were explained?
Okay, I think that counts. Yeah, a summary of the conversation. And so there's a lot of different things that you could include, and this is just some examples up on the slide. Okay. All right.
We would like definition and importance for 500, please.
Okay. By clarifying roles, responsibilities, and limits, informed consent helps establish these between a provider and patient or client, ensuring professionalism and mutual respect.
What is boundaries?
Excellent. Good job. All right, who's next?
I would like to take documentation for 500, Karen.
Documentation for 500. Effective documentation of a patient client's refusal of treatment involves several elements. Name one important piece of information to include in the medical record when a patient declines treatment.
That the patient is aware of what the risks are of declining treatment.
Excellent. All right, who's next?
Okay, information sharing for 500, please.
Information sharing for 500. Providers may use these educational tools when communicating with patients or clients to help summarize key points, illustrate complex concepts, and allow the patient or client to review information later.
What is a handout or visual?
Excellent. Written materials or visual aids. There's lots of different options available to us. All right. Any of the blues? Sorry, the blues are left.
I'll go with principles of consent for 400.
Principles of consent for 400. This document should be consulted by physical therapists to determine when written consent may be legally required for specific procedures. Yeah, yes.
The code, the regulatory code?
Correct. Your Jurisdictions Practice Act, laws and rules.
Thanks.
Good job. All right.
Okay.
What's up?
Can we do information sharing for 400, please?
Sure. Patients or clients should be encouraged to do this throughout a plan of care to help clarify uncertainties they may have about their treatment.
To ask questions?
Excellent. Good job. All right. Back over here.
Let's do definition and importance for 400.
Okay. Failing to obtain informed consent can result in negative consequences. Name one potential consequence.
What is litigation?
Sure, yes. Legal consequences or damage. Excellent. All right.
Capacity to consent for 400.
This term is often confused with capacity, but it refers to the individual's ability to participate in legal proceedings and is not determined by physical therapists.
Oh. What is competence?
Correct.
That wasn't me.
How much time?
All right, so what should I take?
How much time?
Oh, no.
Like 5 minutes, less?
Okay.
Okay. Christina, we have 5. All right, who's next?
Okay, so
Yes, what am I doing?
information sharing. Okay, hello everyone. Information sharing for 300.
Okay. Patients or clients must give this before others can participate in the informed consent discussion.
It's permission.
Yeah, explicit permission. Yes. Correct.
I did that by myself. Okay.
Don't you guys feel good about what you know? Our thought was also that this could be used for students, especially in the earlier levels when these concepts are new to them. All right, over here, or where?
I'd like definition and importance for 300.
Okay. The use of this must be disclosed to the patient or client before it is used when collecting medical history, recording treatment discussions, or documenting informed consent.
What is AI?
Correct. What is the use of technology, including artificial intelligence?
Oh, that was a good one. That was a steal. All right.
All right.
Let's go with capacity to consent, 300.
All right. This legal document may designate someone to make healthcare decisions for a patient who lacks capacity.
Oh, probably their durable medical of attorney.
Yes, so a personal directive, there's lots of different names for it depending on the jurisdiction, but advanced directives and, all right.
We're going to go with
Or losing control.
principles of consent for 200, please.
All right. This professional is responsible for obtaining initial consent prior to beginning the physical therapy plan of care.
The PT?
Yes, the PT. Back to the board. Good job.
Oh.
Just
I can't-
driving that point home. You can't have anyone else do it. Your aide can't do it. The secretary at the front office can't do it either. Mario, are you up?
Yep, capacity to consent for 200.
Which what capacity? All right. This person must provide consent if a patient or client is found to lack capacity.
Guardian?
So in the case of a minor, a guardian, but it could also be a legally authorized representative in the case of someone with other capacity issues. Good. We're going to get through it, I think. Almost. All right, who's next?
All right, we're going to do documentation for 200.
All right. This action must accompany completion of a written consent form to ensure ethical practice. This action.
We're going to say give them a copy.
A copy. Okay.
What
We'll
is
give you half
signature?
credit for that. That's good to give that to them, but that's not the answer, but you can have some.
What is signature?
No.
Oh.
All right, we're just going to give this one to both of you for a conversation, okay? So you have to make sure you talk about it. This is hard. All right, where are we at? Go again. Yep. Okay.
Information sharing for 200, is that still up there?
Providers should avoid this type of language when explaining treatment to ensure patient understanding.
What is medical jargon? Because it should be like.
Correct. Good job. All right, we're now up to the airhead candy, I believe, right? For 100. Where are we at?
Definition and importance for.
Was that documentation? Documentation? Okay. Oh, definition and importance. Sorry, I can't hear over there. This important ethical principle is upheld through the informed consent process by ensuring patients and clients can make decisions about their own health. Where's Nancy
Autonomy.
Kirsch? Yes, correct. Autonomy. Great. Okay, what do we have over here?
Capacity to consent for 100.
All right, capacity to consent for 100. Patients or clients under this age are generally presumed to lack capacity in most jurisdictions.
What is 18?
What is 18? Make sure you check your jurisdiction because it does vary.
Good job.
Okay, over there?
Documentation for 100.
All right. Proper documentation of informed consent is a legal safeguard that helps protect this individual.
What is the patient?
Yes, and the physical therapist. Both of them are correct. All right, we can make it through the last two questions. Where are we at?
Yeah, I think we'll go with information sharing.
Information sharing for 100. This patient education method involves asking the patient to repeat the treatment plan back in their own words.
What is teach back?
Correct. What is teach back?
Thank you.
Last question, and then we're going to put our evaluation code back up again, so please stick around or grab it outside to make sure you can do that. All right, where are we?
I think we have no choice.
Yep. This type of consent is given through actions or behaviors of the patient or client, such as nodding or actively following provider instructions.
What is implicit?
Yes, or implied consent. Back to the, good job, implied consent. Do we have a winner, team?
All right.
Do they have to do math over here? We'll give them a moment to do their math, and I'm going to put back.
All right.
Yeah, we will.
Well, I
All right, we have just a few more minutes and want to.
Fives over there.
Wow, everybody's competitive in this group. A bunch of PTs, huh?
Shocking.
I'm shocked.
Okay.
All right, listen
All
up.
right, guys. Well, they total.
Right.
Well,
yeah,
the winners
so
get their photos taken over there and their stickers.
I don't think we know who won yet, do we?
Guys, you guys are worse than my students.
Is it time?
Attention! All right, guys.
Oh my God. We need a tiebreaker.
All the eggs in the basket.
We need a tiebreaker. Yes.
For the well, okay, but they each are gonna do it. Then I'm really confused about how we're doing this tiebreaker here. So I can't believe that was a tie. All those questions. Okay, we want you to name as many elements of the informed consent definition as you can.
Just start at one.
Yeah, we'll start at one and go back and forth until you can't go back and forth anymore. How about that? All right.
All right, communication.
Okay. Oh, that's. Ellen, think of the definition. Like, what's in the definition? What are the things you have to? Things that are required. For the, we
Consent.
can go again, I guess. Yeah. What must be in the informed
Disclosure of information.
Yes, that is informed consent.
Disclosure.
Options.
Options. Nature. Don't keep going. Just one at a time.
Benefits.
Benefits.
Nurturing trust. Oh. Nurturing trust. Building collaborative relationship.
Shared decision making.
Yeah, I think they're the winner. Is that what I heard? Okay, I was talking to the aide. Okay.
Team 2.
All right, everyone.
Please.
Guys, please do the evaluation up there. Thank you, and we'll be around for questions.
If you received candy, you should do an evaluation.
Oh my God. Peace out. Yes. Oh, sure. Maybe.
What, about 15 minutes? Ish. 15-ish.
C is for communication. Let's talk it out. O for options. That's what it's all about. N for necessary, essential and true. S for sharing, explaining something new.